Hi, welcome to the section of cardiology. This is Dr. Jaitly. In this section, I'll be talking to you about what is restrictive cardiomyopathy. Is it another cause of diastolic heart failure? The answer is yes, of course. Restrictive cardiomyopathy has a unique feature of a pathophysiological way by which it manifests. One, the heart will fail to diastolically relax, if you will. So there's a delayed diastolic relaxation here. Obviously, it's because of a decreased compliance. So that's another unique feature of a decreased compliance here. And then you have elevated filling pressures. The filling pressures will be elevated because the heart is failing to relax. So the blood that's coming from the top chambers, the atria, is constantly pouring into the ventricle, which is non-compliant. So the filling pressures will obviously rise, right? So in the presence of a non-dilated ventricle here, you have a decreased compliance, you have elevated filling pressures, and therefore a delayed diastolic relaxation. So these are the unique features of restrictive cardiomyopathy. Having understood that, let's move on. What causes the restrictive cardiomyopathy? Well, the prototypes are classical amyloidosis and sarcoidosis. Now, these are systemic conditions. They're not commonly seen, obviously, on your regular bedside rounds or maybe in clinics. But when you come across an amyloidosis or sarcoidosis case, you have to suspect restrictive cardiomyopathy. And I'll tell you another suspicion that's coming down the line in the next couple of minutes. So anyway, so amyloid and sarcoid, these are the classic prototypes. But then other conditions which will also cause various infiltrations within the myocardium here are scleroderma. We know scleroderma is a disease, it's an autoimmune condition where the skin is involved and the tissues are involved and they're very rigid. Endomyocardial fibrosis, so that's again, it's an infiltrative condition. And Loeffler's endocarditis, which is tropical eosinophilic endocarditis. Hemochromatosis, where the iron deposits can be seen in the epicardial layer, uniquely within the myocardium. And radiation-induced or anthracycline-induced cardiotoxicity initially will always be a fibrotic or a restrictive type of cardiomyopathy. So there are numerous causes. If somebody gives a history of radiation to the chest for, say, lung cancer or melanoma or other carcinomas or sarcoma, for instance, and radiation was applied 5-10 years. So it may be a delayed feature. In other words, a restrictive cardiomyopathy can present 5-10 years down the line with that kind of a history where radiation was used for treating a cancer, for instance. And likewise, anthracycline history is also very helpful, like adriamycin given for various reasons. Eventually, anthracycline will cause systolic heart failure. Just note that, because eventually the ejection fraction will start declining. But initially, there's the restrictive cardiomyopathy, which is the norm. Now, clinical features will obviously be signs of heart failure. So they're not so distinguishing, but the fact is that there are certain features that you should really keep in mind. Extreme fatigue, for instance. Anorectic person, obviously, amyloid person will be markedly anorectic. Dyspnea, obviously, and exertional dyspnea, then later on orthopnea, where even laying down will be difficult, and then the classic PND of left ventricular failure. PND is paroxysmal nocturnal dyspnea, where the person classically wakes up at 2 a.m., 3 a.m. in the middle of the night and opens up all the windows and tries to grab fresh breath air. Jugular venous distension, these are common signs, but those are common non-specific signs of all heart failure, or whether right or left. Hepatojugular reflux is a sign of right heart failure, and an HJR is a sign of hepatojugular reflux, as we call it. So that's the compression of the abdomen leads to the raising of the jugular venous pulse or the pressure. That's hepatojugular reflux. It just establishes that there is an increased right-sided pressures. Kussmaul's sign, where the JVP will rise, the jugular venous pressure will rise in inspiration. Normally, during inspiration, JVP declines, but in Kussmaul's, it's the opposite. Hepatomegaly in later stages and later on followed by ascites, which is fluid collection within the peritoneal cavity. And then anasarca, that is collection of fluid all over the body, including peripheral edema and anasarca under the eyes, throughout the face, under the subcutaneous tissues, and of course ascites and pleural effusions and pericardial effusions will set in. And during auscultation, one can appreciate the S3, which is a very loud diastolic heart failure. And remember, S3 is a sign of restrictive or diastolic heart failure. And MR and TR will be present because of the mitral regurgitation and tricuspid regurgitation. Now, one should always suspect when the right heart failure is more than the left heart failure. What causes the right heart failure more than the left heart failure? You begin to wonder that this is a diastolic heart failure, which is secondary to restrictive cardiomyopathy. Now, some leading signs on the diagnostic imaging testings, like if you did an EKG, it's a low voltage complex, but then when you do an echo, you see a hypertrophied, thickened left ventricle. So that tells you why is there a low voltage. Normally, you should, with the LVH, you should see a high voltage. But when you're seeing a low voltage in the absence of any pericardial effusion, and you have a high or thickened left ventricle, that gives you a clue that there is something going on called amyloidosis. Now, of course, characteristic scintillations in the thickened left ventricle or the LV myocardium here that will be seen, like here I'm showing in the right panel, you'll see scintillations here. Of course, I'm not showing it here, but just there'll be characteristic scintillations that will be seen within the myocardium. Those are very diagnostic of amyloid. Primary or secondary doesn't really matter. Thickened aortic valves obviously will lead to mitral regurgitations or aortic regurgitations. And then, of course, you have all parameters of LV diastolic dysfunction, like reversal of E to F ratio, etc., E to A ratio. A biopsy will, of course, lead you to a diagnosis of amyloid, and classically it's done from a non-cardiac tissue, like an abdominal pad of fat. Gingival tissue can be obtained for a biopsy from the gums, and a rectal biopsy. That's a classic, which will give you the amyloid deposits. Now, if there are arrhythmias present, a bilateral hilar adenopathy that's present, and you have all signs of heart failure, suspect sarcoid, because on the chest x-ray, if you did, and you see bilateral hilar adenopathy in an African-American, say, female, these are classic signs where sarcoid will be very highly suspecting. Then you do the Quime test and you do the angiotensin levels, and those will be very suggestive. But then a cardiac MR will be diagnostic because you'll have a high intense areas within the myocardium that will lead you to believe that this is sarcoid. But if you have low intensity in the epicardium, that will lead you to believe it's hemochromatosis, and that is diagnostic 100% of the times. So just so that you know. So both are very, very compatible with diagnosis. So I hope you found this very interesting, and looking forward to seeing you again. Bye.